And good afternoon. It is August 1st, 2024. Our patient presents from Florida. He has 4 bad discs in his back. He's a professional skier. I won't say anything more than that. And we're going to be fixing 4 discs in 6 spots. Okay, we're doing a bilateral 4-5-5-1. Everyone agree? And a right 2-3-3-4. So we're going to have to do this in probably 3 incisions. I'm just going to put some medicine. Are you ready?
I think so.
I'm going to give you a little numbing medicine, sir. Sorry for the discomfort. That's just numbing medicine going in. I apologize. I know it's a little uncomfortable. Everything's okay. You're doing great. I'm sorry about that. All right, so we got the right side injected. We'll do a little bit more on the left side. But we've got 4 discs on the right to fix. All right, yeah, DPRs I'm not worried about. Okay, great. Thank you, Jordan. I'm going to put some numbing medicine. Try to keep him obviously comfortable, but I would like to get the 5-1 with his help. Henry, are we live?
Yes, sir. Of course.
Good. Well, this patient has got back pain from 4 discs, but he's also got pinched nerves. And we're going to fix those 4 discs today. On the right side, shot, we're going to have to unpinch the nerves because they're getting pinched severely. He does not want open surgery. He wants the laser surgery. I don't blame him. I'd be doing the same thing. Let's show our audience all the different causes of back pain. AP?
Yes, sir.
I'm Dr. R. Deuk with the Deuk Spine Institute, and we're going to discuss 30 causes of chronic back pain. Chronic back pain is back pain that lasts longer than 6 weeks, and there are 30 causes of chronic back pain. The most common cause is going to be a disc injury. Disc injuries such as disc herniations, disc bulges, disc ruptures, degenerative disc disease account for 86% of chronic debilitating back pain, and they are totally fixable with the proper treatment. The best treatment for disc injuries is Deuk laser disc repair. Let's take a look at the 5 lumbar discs that can be injured. The most common disc to be injured is L4-5, followed by L5-S1, then L3-4. The L1-2 and L2-3 discs are far less commonly affected. Next, we have facet joints. Facet joints are small joints located behind the discs in the back of the spine. There are 10 facet joints, each paired left and right, L1-2, L2-3, L3-4, L4-5, and L5-S1. The most common facet joints to cause chronic back pain are L4-5, followed by L5-S1, followed by L3-4, in that order. After the facet joints, which account for approximately 10% of chronic back pain, we move on to the sacroiliac joint. The sacroiliac joint accounts with the piriformis muscle for approximately 4% of chronic back pain. The sacroiliac joint is a joint located between the tailbone or sacrum and the iliac bone. There is a left and right sacroiliac joint. In this diagram, you can see the joints turning red, indicating inflammation and pain either in the left or right sacroiliac joint. These sacroiliac joint injuries and pain can be treated most effectively with the Deuk plasma rhizotomy of the SI joints offered at Deuk Spine or Deuk Joint Institute. The 4th most common cause of chronic back pain is a piriformis muscle injury. The piriformis muscle is located in the buttock, and there is a left and a right piriformis muscle. The muscle gets torn, unfortunately, when people bend the wrong way. This usually occurs in patients with orthopedic problems such as hip pain, knee pain, or back pain. By bending improperly, they put the muscle under too much stress and they tear the muscle. The torn piriformis muscle causes severe debilitating pain in the top of the buttock. There is a left and a right piriformis muscle, and this can be treated most effectively with the Deuk piriformis muscle release. This is performed percutaneously with a 4mm incision. The sciatic nerve does run through the piriformis muscle, and many patients with piriformis muscle syndrome also have sciatic pain down their legs, with pain, numbness, tingling, and weakness in the leg that's affected on the side of the piriformis muscle. Piriformis muscle can be treated with injections such as steroids, Botox, PRP, or stem cells. However, those injections always wear off and the patients end up coming back with the piriformis muscle pain that reoccurs. The most definitive treatment for permanent relief of piriformis syndrome is a piriformis muscle release. Next, injuries to the bones of the spine, such as the vertebral bodies, with trauma can cause fractures of the vertebral body. Vertebral body fracture is diagnosed with X-rays or CAT scan or MRI, and they're treated with injection of cement into the vertebral body. Looking at the vertebral bodies, the most common to be affected is L1, followed by L2, then L3, L4, and L5. The sacrum can also be fractured. Finally, the coccyx is the last cause of chronic back pain. You can see in the diagram the red coccyx at the bottom. This comes usually from an injury where the patient falls on their bottom, sustains pain at the tailbone, and this can be treated with injections of the coccyx ligament. These are the 30 most common causes of chronic debilitating back pain, the most common being the disc, causing 85% of chronic back pain, followed by the facet joint, causing 10% of the chronic back pain, followed by the piriformis muscle and sacroiliac joint, which cause 4% of chronic back pain, totaling 99% of chronic back pain, which is totally fixable and curable with the right treatment. Thank you. I'm Dr. Deuk Machen. Thanks for joining us.
Okay, we have accessed the herniation now at 5-1. And shot. We are now trying to get to 4-5. One thing I'll tell you is not easy. He has severe disc degeneration, which makes getting into the herniations a bit more difficult, but I'm very optimistic we're going to be able to do it. Shot. As far as the video you've all watched called 30 Causes of Back Pain, you can see that back pain has more than one cause, and we now know what those causes are. And there are 30, I would say, common. Shot. And they're not all equally common, by the way. Some of them are more common than others. Shot. By the way, when I say shot, I'm telling my X-ray technician, Jordan, to take a picture with the X-ray machine. Part of the problem with this patient, he has short pedicles. Short pedicles mean that there's congenital stenosis or narrowing, AP, and that it's easier for him to get problems with pinched nerves in his back because he has short pedicles. That looks really good. Now, he's had back surgery before. I do know that. And it's certainly not making it any easier for us. Shot. Now, how long has he had back pain for? Shot. AP. Probably going to have to make a second incision on the right side to get to the L2-3. That looks really good so far. Shot? Huh? How long has he had pain? I think a lot of his problem is leg pain, right? Leg weakness. Yeah, he has very bad stenosis or narrowing. We call it stenosis. Shot. Shot. Alright, so you can see how short the pedicles are. Jordan, why don't you show the audience where the pedicle is. That's the pedicle. See the white arrow? Go to back
Yes,
to
we do.
front. It should be twice as long as that. Lateral. It should be literally normal is twice that length. His is half the distance that we should have there. AP, but I can't fix short pedicles. What I can do is get rid of the acquired stenosis, or at least enough of it to relieve his symptoms, and that's what we're trying to do. Lateral. All right, so far looking good. The needle at L4-5 looks fantastic. The needle at L5-S1 is good. It's okay. It couldn't be better, but it could be more optimal in that it's not possible to get better because the facet joint is too big. It's pushing the needle laterally. Shot. But we're going to make it work. We've been in this situation before. I can feel his herniation. Any questions?
At this moment, no current questions.
All right, just to remind you, there are 30 common causes of back pain. The disc herniation or disc problem is number one. It accounts for about 87% of back pain in patients with chronic back pain. All right, we got 3 discs down. We got 1 more to go. I'm going to try starting a little bit higher and a little more medial. Shot. You need to be a little bit lower, right about there. Shot. Is that it? Shot. All right, try to show me 2, 3 a little bit better, like behind there, so I can see where my trajectory is. Shot. That's better. All right. L2-3 is not a common disc to be problematic, but in some patients like him with congenital stenosis where he's born with a narrow spine, it can be problematic. Shot? Because all the discs can be problematic when you have congenital stenosis. Shot? I want to be as low as possible as I get into the foramen. That's looking pretty good right there. He's got virtually no disc left. And people ask me, can you still do the surgery when there's no disc left? And the answer is yes. And should you still do the surgery? I think so. Because the alternative is a really bad fusion surgery that's very complicated and involves a lot of bleeding and pain. Nobody wants that. This surgery is far less invasive, and if it works, which I expect that it will, then he's going to be very happy he didn't have that invasive surgery. Shot? All right, so I'm right at the back of the disc at 2-3, but there's clearly a bone spur and it's collapsed, and there's a lot of calcium and hard disc here, hard disc herniation. Let's get an AP. As long as I'm in a safe area right behind the disc, I can access it with the dilator later when he's more asleep. And yeah, it looks good. It looks really good. Yeah, I think we're good. All right, we're going to go to the left side now. We're doing left 5-1 and 4-5, correct? So how's he doing, Dr. Burndas?
He's doing well.
Shot?
Vital signs are perfect.
Oh, that's wonderful. Vital signs are perfect. How's our first lady doing? Shot?
All right. She had a little bit of an anxiety panic attack in recovery, but she's waiting
Shot?
for perfect vital signs.
Good.
Full picture.
Shot? Once again, the arthritis in the facet joint, which you can clearly see. Is that it, Jordan?
Yes, sir.
The arthritis in the facet joint at L5-S1 is somewhat blocking our access to the disc. Shot? That's it?
Yes, sir.
I want to get further south. Shot? That's better. I want to crawl along the lateral border of the facet. I was nice and south, but shot? Somehow managed to get back up there to the north. Shot? Shot? Shot. Is he awake?
How you doing, my friend? You okay?
Really hard to get in here. AP.
How are you doing? You all right?
Is he awake? Huh?
How you doing? He's not awake yet. How you doing? You all right? Oh.
All right, so that looks, we're a little bit lateral to the disc. Thank you. Let me see where we are in the lateral view. Yeah, we need to be a little more medial, which the facet is hitting me and pushing me away. Hmm? Oh no. I'm just trying to see what we can do here. No. Yeah, later on. It's just tough. Once again, I'm having a hard time here because he's got literally so much arthritis in that facet that it's pushing me south, my needle south, of course, where I don't want to go too far south. South. 35 years of back pain. Well, let's hope we can fix that for him today. Any questions from our audience, Henry?
At this moment, no current questions. So in the meantime, why don't we show the audience of how it is a herniated disc causes back pain?
Sure. AP? Or lateral, I mean?
Disc injuries start with an annular tear, damaged nucleus. Pulposis herniates into the annular tear. The herniation triggers an inflammatory response within the annular tear. The inflamed annular tear generates pain signals.
All right, welcome back. You can see from this video that we just showed you that the disc is able to create back pain through a process called inflammation. And that inflammation comes from a tear in the back of the disc called the annular tear. I'm trying to get into this bottom disc on both sides. AP. The problem here, folks, is the spine is very far forward, and you don't know that until the patient comes in the operating room. It's impossible to tell how far forward it is. But also, he has this arthritis in the facet joints, which are behind the disc, and you got to go past the facet joint with a needle to get to the disc. And so you can see all that arthritis. Jordan will show you. And then on top of all this, he has a short pedicle at 5, which makes the foramen very narrow at 5'1", and it makes it very difficult to get in. I need to know when he's awake, fully awake. I can get 4-5.
How you doing, my friend? You okay in there? Good. Thumbs up.
Is
right?
he okay?
Yeah, he's fine. Give me the thumbs
No, but
up.
are you sure? He's reliable. He's reliable.
Yeah.
100%?
Raise your thumb up for me. Good.
Are you having any pain in your back?
Are you having any back pain? Yes or no?
Any pain down the leg?
You said no, right? No. I can't
Sean?
have you shake your head. I gotta say answer yes or no. No pain in your leg? No. No pain.
Any pain?
No. Nope.
Really? That's amazing. Give me an AP. I just don't trust the 5'1". Shot. It's right there. So close. I might be able to get a guide wire down there. Right? No pain down your leg?
Yes or no? Any pain down your leg? I couldn't hear you.
Shot.
No.
All right, well, I'm going to try a discogram at 5'1" on the left, just to see if we're in the disc. We're almost done, sir. We're going to have you asleep in a few minutes. Shot. I've got to get one more needle in place. And all the surgery is done by using needles to guide my instruments to where they need to go. Needles are very minimal invasive. We like needles because we can steer them and guide them, Sean. Make them go where we want them to go, usually. And the only thing that limits that, obviously, is the patient's own bone. If the patient has bone that's blocking, and this patient does, by the way. Are you comfortable?
Are you comfortable, my friend? Yes.
If the patient has bone that's blocking my access to the disc, then I can't get past it. It's impossible. The needles won't go through bone. So that looks good. That looks good. I'm just a little... 5-1 is the worst. It's the hardest to get to. I'm a little concerned about 5-1 here, and I want to make sure that we are in 5-1, at least on one side. Shot? I can tell you he's a professional skier. I can't say anything more than that. All right, I'm gonna, let me have a dye. I'm gonna check the L5-S1 and see if it's in the disc. Are you comfy?
Yeah.
Yeah?
Yes.
Shot? Oh, it is. It's in the disc. How bad is that on a scale of 1 to 10?
Give us a number.
How bad is that pain?
Speak the number. 9.
9. Is that where you get pain? Is that where you typically get pain? Yes? All right, good. So 5-1 is a 9 out of 10. Great. We found one of your bad discs. By the way, you can see, you know both needles are in the 5-1 because the dye is coming out the right side needle when we injected the left. That means they're communicating inside the disc, which is great. That tells me both needles. You can see a giant tear at 5-1. See that, Henry?
Yes, we do.
All right. I'm going to test another disc while our patient is still awake. How bad is that on a scale of 1 to 10?
Give us a number. 9.
Is that where you get your pain?
Yep.
Yeah. All right. So L3-4, I tested L3-4, 9 out of 10. You guys can see that one is torn also.
Yes, we can.
All right. Is it better? Is it better now?
Yes.
How bad is that on a scale of 1 to 10?
What number?
9.
9.
Scott, 999. Is that where you get your pain? That was L4-5. Lay still, don't move. You're doing great. We're almost done. We're going to put you to sleep in just a minute. Huh? Yeah, I don't know. I'm going to find out. So, for everybody watching and for my nurse, guys, he had 9 out of 10. No. 2-3 is not it. No. I have, yeah, you can put him to sleep. I'm going to do 2-3, but I'm going to, it's so collapsed. I'm going to try to get in there. Shot? I'm going to try to go a little further south. Shot? I mean, it looks good on the lateral view, but there's just no disc space, you know? So I'm gonna get in. No worries, don't worry. Have I ever disappointed you? I mean, I can't get in once in a while, but it's very rare. Okay, great news. So we know the 3 discs are causing his back pain. We couldn't test L2-3 because I can't get all the way into the disc with a needle. I'm going to wait till he's more asleep, and then he'll be relaxed. His muscles will relax here on the side of the spine, and the disc will open up naturally for me. All right, you guys ready? So let's start with number 3-4 if you want then, right? On the right. Any questions?
At this moment, no current questions.
Shot? All right, I'm just going to work then. I'm going to tell you all something. His discs, he doesn't have normal discs, guys. His discs are 90% collapsed. But that doesn't mean he can't have this surgery. This surgery works to get rid of back pain, and it works to get rid of leg symptoms from pinched nerves, even if the disc is 90% collapsed. That's why I thought the surgery was still a good idea. Come on, Jordan. Even though his discs are collapsed. I get that question I get asked a lot. If the disc is completely degenerated or collapsed, can you still do the surgery? The answer is yes. It just makes it harder, but the results are typically the same. So I'm up against a bone spur right now. And the good news is my aim sucks, but I'm able to use several tools at my disposal, like my hammer, to fight the bone spur with the tip of the dilator. Hold on. Let's see. Yeah. Shot. Go ahead. So I can actually... Yep, I just did it. We just open up the disc space. You see that?
We did.
You see the space, the white color between the bones? That means the disc space is opening. And that's good. That's what we want. All right. How is he, Dr. B? I know. Isn't that wonderful? You have Richard to thank. I already chewed him out.
Never discussed it.
Wasn't discussed with me either.
Got a long day out.
No, it's not that. I mean, I've given very clear instructions. I like my instructions to be followed.
We have a comment coming from Dale on Facebook
Yes, Dale, happy to take your comment.
saying, I'm interested in how these patients do 5 years plus down the track after receiving the surgery.
Well, Dale, I'm very happy you're interested. The patients do fantastic. The pain that they came here for with their disc is gone. It's gone 5 years, 10 years, 15 years. We haven't hit 20 years yet, but we've gone up to 18. The patients we did 18 years ago, their pain is still gone from their disc. Now remember, people can get pain in other discs that we didn't treat. They can get pain in their facets. They can get pain in their SI joint. They get pain in their piriformis. They can get fractures. They can get coccydynia. So there's more than one cause to back pain. But the pain that we treated with the laser surgery is gone, and it's permanently gone. We've never had a patient where it didn't go away. Not a single one. I was a bit surprised too. There's a piece of herniation. Yeah, when I started looking at the numbers. We did a long-term study on the lumbar patients, and we found that if we made the cutoff 5 years minimum, 5 years of follow-up, that if you look at the patients that have a minimum of 5 years follow-up, they had 95% of their back pain was still gone. The pain that we treated them for, okay? Their disc pain. Because that's all we're fixing here is disc pain. 95% gone. Let's get a grabber. And the average amount of follow-up was 7 years, okay? I think it was 7 years. It's either 6 or 7 years. I can't remember. It's been a while. So, minimum 5 years to be in the study. And the average follow-up, I want to say it was 7 years. And they had 95% of the back pain still gone. There's no surgery in the world that has that result besides ours. You won't find that with fusion. You won't find that with artificial disc. I want you to notice how inflamed the end plate is. You got to watch this needle here. When my hand is hitting it, I need you to hold it and not let it move. Because I'm struggling to pull the tube back. All right, so I'm pulling this tube back, and there's where all the back pain comes from. That little thing dangling down. It looks like a little pink piece of fruit, but that's the inflammation. Remember you guys watched the video, Henry, where it shows
Yes.
how does a herniated disc cause pain, and then you guys saw the inflammation happening. That is the inflammation. Even when there's no disc material left, inflammation still happens. Now we've been using a new set of cameras. They're a company that is allowing us to try them out. It's called ConMed Limitech. And I've been really impressed with the quality of the pictures, but the price tag is equally impressive. How much do you think a camera will cost? All right, so imagine you want, what is this, 4K?
Correct.
4K camera. Henry, how much is a good, really good high quality 4K camera if you go to Amazon or CNET?
Amazon, CNET, Best Buy, give or take 4K, a good one, $600 to $850 retail.
All right, 800, so $1,000.
Yeah,
right?
let's go $1,000.
$1,000 for a camera. What about if you were to add some memory?
If you wanted to add storage to that, that can add another maybe 80 to $150. So let's go 150 right there.
All right, so the 800 plus 150, let's just make it 1,000 for the camera and memory, right?
Yes.
$1,000. I think most people watching would agree. These cameras are $100,000 each.
Good Lord.
Yeah. Did you hear Henry? I think that was Henry's.
That was me.
That was Henry's mitral valve.
Like, oh my
Yeah,
goodness.
right?
Yeah.
So people are like, I laugh at him online. I mean, I don't laugh. I laugh, but I don't laugh. They're like, why is the surgery so expensive? I don't know, man. Maybe you should do your research and figure out why. Healthcare is so damn expensive. And honestly, it doesn't need to be. It's ridiculously expensive. I don't make it expensive. I just have to pay the bills. But I think everything we buy is literally 100 times more than it costs for people to make it. And yet, unfortunately, that's how healthcare is. You know, when Obama was president of the United States, I think he shut down NASA, right? Wasn't it Obama who shut NASA down? Do you know why he shut NASA down? Honestly, we live where NASA is. We're right here by NASA. When I heard he was shutting down NASA, I was pretty upset because he shouldn't be shutting NASA down. But the reason he shut down NASA is pretty sound. The costs of running NASA by the government were out of control. And the reason they're out of control is the same reason healthcare is out of control. The people that supply things to NASA were just overcharging NASA by massive amounts of money. So Obama said enough is enough. Stop ripping our taxpayer and government off. Okay? I am not a big fan of everything Obama did. I'm just going to say that as a statement. I'm not going to say anything more, but Obama was right. We were overpaying for everything for NASA. And, you know, a cup of coffee at NASA would cost $50. I'm just using that as an example, right? Not for, you know, people like us going there as visitors, but that's what it would cost the government to supply a cup of coffee to the people that work there. How do I know? We have a lot of patients. Okay? Watch. Just a lot of taking advantage of our government and therefore the taxpayers with a lot of these industries where the government is the purchaser. And the same thing happens in healthcare, you know. I love the scope. It's got a better picture than our normal scope, but I can't afford $100,000 a camera. And for me to buy that, I'd have to pass that on to patients. And I can't ask patients to spend more money than they're already spending on their surgery just so I can have a prettier camera. For 18 years, we've been doing this surgery right here with the cameras we've been using. They're high definition camera. They're not 4K. They're probably 1080p, something like that. And they work fine, you know. The picture's not as good. I'd like to have a nicer picture, but I can't justify spending $500,000 for 5 cameras. All right, any questions, Henry?
No current questions, so we do have a comment coming from Dale once more on Facebook saying,
Sure.
I think you mentioned 2 weeks ago that the laser was 500,000.
No. Dale. I don't know what you're talking about, Dale. You can go back and listen again. The camera system is 500,000, not the laser. I don't think the laser is 500. The laser is about 125,000 a piece. The laser runs about 125 grand a piece. The camera system we're looking at for the last 2 weeks is 500 grand. That's 100,000 a camera. No, it's just, it is overpriced. It's overpriced.
It's like the OR TVs.
You know? But here's the God's honest truth. The company that makes that camera, they go out and they sell their cameras, and then nobody needs to buy another one, right? For a few years. Like we've used ours for what? 18 years? We'll use ours for 20 years. So what does that tell you? It tells you the cameras work well and they're made well, but how is the company going to make money and pay its bills when we're not buying any more? Right? So I get the fact they need money, but so what they do is they realize we make a good product. If we sell it to people, they'll buy it, but if we charge 500,000, that will give us enough money to keep going for a while. But it's too much for most hospitals and surgery centers to pay for. Just can't afford it. And yet they need that money to keep in business. So it's a calamity of errors here. It's a very bad situation to be in for them. For us, I just won't buy the camera. I can't afford it. For them, they've got operating costs and overhead. All right, this is the herniation part of it. I've told you guys in the past, you have to look to the side. We call it laterally in the foramen. You can see there's this bit of herniation here. I want to try to get as much out as I can. I want to give this guy another 50 years. Pain-free, that's my goal. All right, any other questions?
No current questions, so in the meantime, why don't we show the audience of how the Deuk laser disc repair works?
Oh, I think that's a great idea. I think there's a little piece of bone right there I might be able to get some pressure off the nerve. While you're showing that video, I'm going to keep working.
Copy that.
Disc injuries are a common cause of chronic back pain. The inflamed annular tear causes back pain. A 1/4-inch sized skin incision is made. A small tube is inserted with no damage to the bones or soft tissues. The laser removes the herniation and debrides the annular tear. The annular tear heals on its own after the procedure, which can take up to 12 months. For more details, please visit our website or call us at 1-800-FIX-MY-BACK 349-6922.
All right, welcome back. We were just talking about how I was cleaning up some arthritis on the facet joint there. And one thing about having short pedicles that you're born with is that your facet joint is going to be a lot closer to the back of the disc than, a normal person. And so that I just came out of the disc and I saw the facet there, and I took some of the ligament and bone spur on the facet joint out to help unpinch his nerves. So you don't always get to do that because most of the time the facet joint is further back towards, this way. You don't see it. Okay, next let's bring the fluoro in. We've got a lot of work still to do. We're going to do number 4 or 5 next, right? Go ahead, Jordan. Bring it in. Any questions? I'm happy to take your questions.
At this moment, no current questions.
Num num. How's he doing, Dr. B? All right, Henry. Are you showing a video?
No, we came back from the how to cure lower back pain. We came back.
With the Deuk laser disc repair?
Yes, correct. We came back from that.
Well, what about facet pain? I think
We have not shown either. No, we have not.
Let's do that.
Yes, sir.
Well, that was quick, Henry, but you showed our audience how to cure facet pain.
Oh, no, I showed them how, I apologize. I showed them how facet joints get inflammation. I will now, yes.
Yes, of course. Well, that's important too. Hold on. Hold on. Shot? Uh-huh. All right.
Yes.
Try it, yeah. Mm-hmm.
But I will play how to cure facet pain with the DPR.
Good. So now you understand how we use the Deuk plasma rhizotomy procedure to eliminate facet joint pain by basically cutting and destroying the pain nerves to the joint. The procedure is called the rhizotomy. It was not pioneered at Deuk Spine. The rhizotomy was not, but the way that we do the rhizotomy was. All right. We are now on the right side at L4-5. And you can see the pink tissue once again. The pink tissue represents inflammation inside the back of the disc. This is where his back pain comes from, along with his facet joints being problematic. You can see little pieces of herniation floating around. I do apologize that the view is not any better. Thank God I know what I'm doing. I could tell you this is a elite athlete that we're operating on. People ask me, do you operate on any elite athletes? The answer is yes, we do. This is one of them. I can't tell you anything about him or what he does. I don't want to give away his identity, but yeah. He found it very difficult to do his work, his profession, because of his back and leg, and we're gonna hopefully fix that for him. One thing to keep in mind, when you fix a pinched nerve surgically, you go in and unpinch it. Sometimes the pinched nerve starts working just perfectly normal right away, but usually it takes a few months for things to start working right, and I've seen it even take up to a year. So patients just have to be patient. I tell them, be patient. Now, if you're having some issue, I want you to let me know, because it may not be a pinched nerve that you're having an issue with. It may be something else. And I want to know if there's something else going on. So I always encourage my patients to communicate with me personally as their surgeon. I give each and every patient my phone number, my cell number, and I literally carry my cell, and they can call me, text me anytime. I think that's important to have that connection with the patient so I can get feedback from them. If there's any issue going on, I want to know about it. I'd rather them tell me early than late. All right, any questions?
Yes, we have a question coming from Tracy on Facebook
Sure.
asking, when performing a piriformis release, is there a risk of injuring a peripheral nerve? Like if a nerve were to be injured, would it likely result in numbness on the skin rather than causing pain? Thank you.
Hi, Tracy. Is it possible to injure a peripheral nerve during a piriformis release? The answer is yes. It's always possible to injure a nerve anytime you do surgery of any type. Okay? Is it likely? Look at this. That's where his pain's coming from. That's the inflammation. Guys, go back and watch the video. I'll have Henry show it to you again. That is the inflammation I've been talking about within the annular tear where the herniation is. The herniation being blue, the gold color is calcification or calcium, the white is scar tissue, and the pink is the inflammatory tissue. Tracy, the thing about our Deuk piriformis release is that I personally developed the technique, and I developed it in such a way that we're releasing your piriformis muscle in the one place where it is the least likely to have any type of a complication. It is literally the safest place to release the piriformis muscle. And that is where it attaches to the trochanter, okay? So that's why we selected that. There are no peripheral nerves over there. There are tiny nerves, that everybody has throughout their whole body. They're unimportant ones. The only thing over there is the muscle and where it attaches. There's no important arteries, there's no important veins. There's no important nerves. It's very safe. That's why I selected that spot. And that's why we've not had any complications since we started doing the procedure. What you can have though, and does happen, is people get pain in the area where I do the surgery. Why? Because, oh man, look at all that pink tissue there. That's beautiful. Henry, you want to keep that?
Yep. Doing that right now.
That's great for the website, right there.
Copy that.
You can even see a bit of fat in the epidural space. All right?
Alrighty, got that.
All right. It's another granulation tissue in the annulus. Got some really good ones over the years. That's a good one. Long story short, Tracy, the piriformis muscle runs from the tailbone, sacrum, all the way over to the hip. And along the entire course, from its origin on the sacrum down to its insertion on the hip, it is dangerous to release it. There's only one place it's not, and that is exactly where we release it. We tried to do it endoscopically, arthroscopically at first. It didn't work. It was just a mess. We couldn't see anything. Couldn't see what we were doing. So we abandoned that technique. And then I realized we're really overthinking it. Much simpler way to do it. And that's without the endoscope or open surgery. Being done right now is endoscope and open. So we created a whole new way of doing it. It's called percutaneous. That was my development, my baby, as is the Deuk plasma rhizotomy and the Deuk laser disc repair. So thank you for your interest. This is a piece of herniation that was pinching his nerve. And look at that thing. Here it comes. It's coming out. Just got it out. Beautiful. All right, we are done with this disc. You can see a little bit of fat right there in the epidural space. This is a little bit of bone spur. I'm going to just zap it. It's already gone. People ask me all the time, can you get rid of bone spurs with a laser? Well, there you go. Question answered. Any other questions, Hen?
At this moment, no current questions.
Let's show the audience then once again the inflammation that we're talking about.
Copy that.
Disc injuries start with an annular tear, damaged nucleus. Pulposis herniates into the annular tear. The herniation triggers an inflammatory response within the annular tear. The inflamed annular tear generates pain signals.
Okay, great. So as I said, if you rewind the video just 5 minutes, you'll see we had a big piece of inflammation right where the herniation was, and it was really pink. And just like the video shows, that's where all the back pain comes from. And we were able to find it and zap it, get rid of it. Okay, so moving on to the next disc, which is going to be the L5-S1, left side. I apologize, right side. Thank you for correcting me. You're fired. No, I'm just kidding. I'm just kidding. At least Nikki and I have worked together for a while. She knows my sense of humor. It's very New York style, right? I have a northeasterner sense of humor. Are you going to New York tomorrow?
Yeah.
Why would you ever want to go to New York?
My
Hey.
best friend's surprise 60th birthday.
Yes, Henry.
No, I was just, he was like, why would you go to New York? I was like, hey, come on. I'm from there.
Listen, I'm very happy in Florida, okay? Give me a good reason to go to New York. It's crowded. Shot?
Best friend's birthday?
That's a good reason. Shot? All right. Yeah, best friend's birthday is a good reason. Where in New York are you going to be?
He's Colton's godfather. Glen Cove, Long Island. Where town I grew up in.
Long Island. What do you mean town you grew up in, Dr. B? Don't give me that nonsense. No.
I moved out of there when I was 7.
You told me you grew up in Fort Lauderdale or Boca, right? How many places have you grown up?
Well, I lived there, when I was young.
All right. I'm just giving you a hard time.
College in Florida, med school, Florida, residency.
But you lived in New York, in Long Island. Nice.
It's nice in the summer. It's beautiful.
Yeah?
Nice, very nice.
In New York?
Agreed, yes. It's beautiful.
No, don't say yes, Henry.
It's beautiful.
Give me that shit.
Ah,
I'm going to send you some pictures.
yeah.
Listen, my mom grew up in...
I'm going to text you a photo from this back.
I believe you. My mom grew up in Queens. She said it was so hot in Queens. I don't know.
Hotter there, yeah.
In Queens?
3 or 4 or 5 degrees hotter. Yeah. Well, he's right on the water.
He's right on the water.
Right on the water, yeah. Like boat in the backyard. Yeah.
We have a question.
Hold on.
Not a problem.
Shot? Let me just get this real quick. This is the hardest part right now. The hardest part of the whole damn surgery.
Yes.
All right, go ahead. Give me 1 second, Henry.
Not a problem.
Shot? Yeah, we got it. Hold on. I just want to make sure I have the other side in. Yeah, we're in. All right, good. Sorry, go ahead.
So
This.
did you ever read the Great Gatsby?
Yeah.
So the East Egg and the West Egg and the islands that they were referring to in that book. So I lived on East Egg.
Ah.
Morgan's Island, owned by J.P. Morgan, the famous railroader.
Yeah, financier.
Financier.
Sorry, Henry. Give me a second. I'm just having
Morgan's Island.
Not a problem.
a talk with Dr. B.
Of course.
All right, Henry. What have you got?
This question coming from Denise on Facebook,
Hi, Denise on Facebook. How are you?
asking, so all that pink was inflammation.
Yes.
How does the laser fix the annular tears? And also, do you just remove the inflamed tissue and does it heal on its own? Or can you explain more of the patho/physiology
sure.
of all of it
Be
all?
happy to do that. We've done it before. We've explained it all in detail, but the video explains it as well. So Denise, what happens is people have an accident to their back. They tear the wall around the disc called an annular tear. And then once that tear is there, the jelly from the center can get out. Yeah. And it gets out through the tear. It actually pushes into the tear and it gets stuck inside the tear. And when that jelly is inside the tear, guess what it does? The body's inflammatory system attacks it. There it is. That's perfect right there. Henry, this is a perfect picture
I could not agree more. Yes.
for the website. Why? Because you got the blue herniation, you got the pink inflammatory tissue, and you got the annular tear all in one picture. Can you get that, please? Oh,
Yes.
just farted.
Already got it. All good. Looks beautiful.
All right, so I want this picture, okay? It's very important.
Yes, sir.
Why is it important? Because you could see the inflammatory tissue caused by the inflammation. The blue is the herniation right there. The annular tear is right there. It's that little yellowish thing. All right? So the annulus tears, makes a crack. The blue is the nucleus escaping, gets stuck in the annular tear, and then the body's inflammatory system sees it and attacks it. And that is where all the pain comes from. All the pain. All the back pain. 85% of chronic back pain comes from that exact spot. It's a tiny little spot. So fixing it is pretty easy. We do it arthroscopically. You're seeing it right here. I don't know if I answered your question for you.
I believe so. It was like a few questions in one, but all in all, I think you covered it.
So I'm trying to explain. You get an annular tear, you get a herniation into the tear. The body's inflammatory system sees that herniation stuck in the tear and attacks it, trying to heal the annulus. But it can never remove the herniation because there's too much. And your body just attacks it for years. And the person has back pain from that. Until Dr. Deuk Majan and Deuk Spine Institute go in and basically remove the herniation and clean the tear so that it will heal. It's called a debridement. In medicine, we call it a debridement. Annular debridement. Great question. Any other questions?
Other than that, no current questions.
All right, good job, Henry. You want to show any more videos, or have we shown them all?
We pretty much shown them all. This next one that we have not shown is just how the laminectomy is performed and why should patients avoid that at all
Avoid
costs.
it. Let's do that. Because that's true. His other option is a laminectomy. But the laminectomy will make his back pain worse. It'll help with his leg symptoms, but it'll make his back pain worse. Laminectomy does not fix back pain. It fixes leg symptoms if it's done properly and you're lucky. It does that maybe 50% of the time. But it never fixes back pain. Laminectomy never fixes back pain. So the back pain requires a separate procedure on the disc. Laminectomy doesn't operate on the disc. It only operates on the lamina. Okay. Go ahead, Henry.
Copy that.
We were just talking about one of our patients from Tuesday, a young lady who had a lumbar Deuk laser disc repair for L4-5. She was doing so well yesterday, the day after her surgery, she contacted me and asked if she can go get a tattoo on her body, on her arm. Said, I won't put it on my back where you did your surgery, but I want to go get a tattoo. I said, sure, go ahead. The day after back surgery, she's going out getting a tattoo, huh? Isn't that fascinating? All right, Henry, any questions?
No current questions, so we do have a comment coming from Denise, once more on Facebook,
Denise, please, by all means, feel free.
saying, very interesting, great to see these live videos, and thank you for the education and being so transparent as a doctor.
You are more than welcome. It is my pleasure. I enjoy being truthful. I enjoy teaching people the truth, letting them know the truth. I just think people deserve to know the truth. I mean, of all things, right? If you're going to go to McDonald's and eat a burger and they're not going to tell you what's in the burger, they're going to be dishonest with you. That's one thing, right? It's kind of gross. But your surgery is a big deal. And doctors really need to respect the patient's right to know everything about the surgery plus other options that are available besides what they're recommending. And that's just not being done. So there's a name for that. It's called informed consent. You may or may not know that. Patients are supposed to give informed consent. It doesn't matter what state you live in, Florida, California, New York. If you have surgery or any treatment, you're supposed to give informed consent. Informed consent has two parts to it. Consent, which means you're agreeing. Informed means you're informed of the treatment, how it works, but also what are the alternative treatments that are reasonable and potentially beneficial, and what are the potential problems that can happen with treatment. So what's happening is all these spine surgeons are offering patients highly invasive surgery like fusion, artificial disc, but they're not telling the patient about their alternative treatment that's available. They're basically lying to the patient. Therefore, they are not getting informed consent. And I think that's an injustice. And I don't like it at all. I'm very unhappy about it. It bothers me to know that people are having invasive surgery without proper informed consent. And so I want people to know the truth. Yeah, it's important to me that people know the truth. It's just something I take seriously. I don't know. It's weird. I'm a little bit different than my colleagues. All right, we're done here at L5-S1. Once again, this patient does not have a lot of disc herniation to remove. They're all dried up. He's basically been suffering how many years? 35 years. 35. With back pain, leg pain getting worse, weakness, numbness, and suffering. And he just put off surgery because all that was offered was invasive surgery. He wasn't going to do it. Given the fact he's a pro athlete, he wasn't going to do a fusion. And then he found us, and he came here, and now he's getting this done. And I really believe he's going to be very... All right. We're done at this one. We're going to move on to the next one. And we have a lot of work to do. I made an exception for him. Normally we only do 5. We made an exception and to do 6 spots. It has nothing to do with my comfort. It has everything to do with what's safe for the patient. We're also going to be treating his facet joints. It's clogged. That's clogged. Any questions?
At this moment, no current questions.
Good. Thank you. Excellent. One more to go on the right, 2 on the left, plus some facet joints, and we'll be done. Jordan is going to bring the X-ray machine back in. We call it a fluoroscope. It's the top of the line in the world. We only use the best of everything. here at Deuk Spine Institute. The best lasers, the best fluoroscopes. The fluoroscope is a $160,000 fluoroscope. The laser is a $120,000 laser. You all heard the price of the new cameras. They want $500,000 for 5 cameras, high definition. All right, shot? Good. Look at that, Jordan. What do you know? The guide wire went in. Shot? Son of a gun. So I was in the right spot, and now that I told you guys I could not get the needle at L2-3 to go in because he was awake and he was tightening down on his muscles, and I said, wait till he goes to sleep. Dr. Berndez will work his magic. And lo and behold, he relaxed. The disc actually opened up. It just goes to show you, when people have muscle spasms in their back, they pinch down on their spine, and it causes the nerves coming out of the holes in their back to get pinched. So when I tell patients after surgery, if you got muscle spasms, really? There's nothing in there. Just give it time.
Actually,
That was the opposite of extra num-num.
Air numb.
That's right. Air Max.
Right.
Max Air. Any questions from our audience?
Yes, we have a question coming from Denise once more on Facebook asking, is it just one puncture incision with the laser surgery?
Denise, it's a great question. Here you go. So we did one puncture incision for 3 discs, but to get to the 4th one, I had to do a second puncture. So, and then if we go to the opposite side, which we're doing that as well, it's a separate incision. Shot? So normally it is one incision. However, if the patient has anatomy that doesn't lend itself to one incision, it'll be more than one. Man, this thing isn't moving much, huh? Let me just see here. You're good, Berndez. Don't worry, I'll get it. I'll just say, not easy. Holy moly. All right, hold on. Take that. Let's see where we are. All right, go ahead. I feel like I'm working on the railroad. There it goes. It's opening. You guys see the disc open?
Yes, we do.
I am literally taking this stuff to the max. This equipment cannot possibly produce more. Oh, I know it's going. Boy, you talk about a rusty old back, huh? Now it's in. Son of a gun. Woo! All right, I got to be honest, folks. I know that looked pretty bad. That was the hardest I've ever hit one of these dilators to get it in. In 18 years and 2,100 surgeries. Huh? No, thank you. I couldn't do it without you doing your job. Whew. Yes, my hand does take a beating from time to time. Better me than one of my staff. Really? Vice grip. Let's not get ahead of ourselves here. Give me the damn vice grip. I'm just kidding. We got it. I had a better angle than Luis. Plus, I worked out at the gym yesterday. I had a good workout. Lats, bis, tris. And I had Wendy's for lunch. Spicy chicken breast sandwich on a pretzel bun. Plain. That will do it for me, folks.
They had some lunch.
What? Yeah. Yeah, but I didn't eat it. I don't like it. Okie dokie, folks. We're going in. I was going to do it in the dark, but Luis just turned some light on. I guess I can turn the light on. I was going to show off my operating in the dark skills. My night vision. My ninja vision. I was going to go as a ninja in the dark. All right, Henry. I'm starting to get a little loony. Getting slap happy. You're going to have to give me some questions or I'm just going to start saying some weird stuff.
I was hoping some people would ask some questions, but at the moment,
they're enjoying.
They are.
They're enjoying me going slap happy.
We do have a good viewership, that I'll say, but no one's saying
All right,
anything.
viewers, I apologize for the view because it's mostly a little red from some bleeding. Why is there bleeding? Well, the answer is simple. Remember we talked about inflammation happening here, causing the pain? Well, inflammation also brings blood vessels. And blood vessels bring blood. And blood means when you operate over by the blood, you're going to get some little veins and capillaries that want to bleed. And that's what we've got. All right. Feel free to ask me a question or two or three if you'd like. Happy to answer them for you guys. There's that inflammatory tissue again. Scar tissue, calcium, herniation, all together. By the way, since there's no questions, I'll just say Henry, Sanjay, myself, and my team out of Amsterdam, India, wherever else they are.
Stockholm.
Huh?
Stockholm, Sweden.
Stockholm. I'm sorry. I did say Amsterdam. I meant, well, maybe there is somebody in Amsterdam.
I think so, but you're good. All's well.
We are getting ready to launch our website for the first time, a brand new website. I have spent the last 2 years on this particular site developing it, and I've had Henry and Sanjay and the rest of our team. It is amazing. I think it's amazing. It's going to be so informative, and you're going to see things you've never seen before. Like, where else in the world will you ever see inflammation in the annular tear associated with a herniated disc? Where? Nikki, where? Nikki's like, what was the question again? Can I have $30 on, huh? Never. You won't find it anywhere else. We are literally making history with our website in terms of the content and what it has. Because we're the ones who discovered that the annular tear herniation causes inflammation within the annular tear. So basically, you won't find it anywhere else. You're going to see it for the first time on our site. Now, we have had it on YouTube, right? So we had a video on it. But we've got some really new, very, very well done animations. All right, we are just about done here on this disc, Dr. B. About a minute left. A lot of scar tissue right here. That's mostly what I'm seeing. This is L2-3. Remember, this is the disc that was super collapsed. And to be honest with you, it's definitely causing pain. But mostly it's not nerve compression. It's more inflammation pain. So there's a little bit of herniation right there we got to get rid of. And then we're going to be moving on to the next disc. Luis, I need a grabber. I call it a grabber. It's actually a pituitary rongeur. But if I say pituitary rongeur, it sort of just takes the mouthful. Now my son and I have been learning to wakeboard. Wakeboard, if you know what that means. It's not part of the woke movement. That was funny.
I laughed. I laughed. That was good. I enjoyed that.
But, hello, time for you to wake up. You need to become part of that wake movement. Nikki, wake up! Just giving Nikki a hard time. But this is unfortunately the kind of regression and downward spiral of behavior that occurs when you guys don't ask questions. So we just become total degenerates here in the operating room. We just talk about weird things and show our true nature of being weird people.
Speaking of, we just got a question.
Yeah, they're like, save us, please, stop talking.
This question coming from Denise once more on Facebook, asking, what's the usual recovery time and follow-up after a procedure like this? Is there much pain afterwards?
Thank you, Denise. The recovery time is literally 1 hour. Like I said, the young lady, we did her surgery yesterday. She called me today. Sorry, we did her surgery Tuesday. She called me Wednesday morning and said, can I go get a tattoo? I mean, the recovery is literally an hour. And by the next day, people go back to work. They go back to normal living. So is there any pain? Just the day of surgery, there's a bit discomfort. We give you some pain meds like Robaxin, which is a muscle relaxer. That's all, no narcotics. There are no narcotic painkillers with this surgery at all afterwards. You don't need any narcotic painkillers. So it's wonderful for people who don't want to take narcotics or painkillers after surgery because you don't need it. You see how tiny the incision is, right? So we don't do much damage at all in here. All right, I'm just about done, like 10 seconds, and I will be done. I don't know if I answered all of her questions. Hopefully I did.
I believe so. All is well.
All right. Done here. We got 2 discs left on the other side. We're going to go take care of.
We have another question.
Yes.
This is coming from, I love the name, Mud on YouTube.
Nice.
Mud asked, if radiculopathy is the primary concern and not pain in a large lumbar disc hernia pressing the nerves,
Yes.
what percentage of the herniation can one expect to be cleared with the transforaminal approach?
Great question. So this is a very smart question. The person is asking, you know, Dr. Deuk, I get it. You're in there cleaning out the tear in the back of the disc, getting rid of back pain. But what if the person, you know, doesn't have back pain, but instead they have radiculopathy, which is leg pain, or weakness in their leg, numbness in their leg? Then, like, you know, how good is your surgery, the transforaminal, at fixing radiculopathy? The answer is our surgery gets rid of 99% of radiculopathy. Then the question is, how much of the herniation will your surgery remove with the transforaminal? Our surgery removes more of the herniation than any other type of surgery. The other types of surgery, like a translaminar surgery, a little pressure here, those types of surgery that other doctors do, whether they go into a laminectomy or framenotomy, they're not going to get as much of the disc herniation as we do. And that's because they can't get the part of the disc herniation that's in the foramen or lateral recess. They can only get the central and paracentral disc herniation. And causes symptoms is in where we are, in the foramen or lateral recess. So the best surgery for getting rid of the herniation that's pinching the nerve causing radiculopathy is this surgery. Far better than microdiscectomy, laminectomy, or any other type of procedure that's available out there for radiculopathy. Does that make sense? Are we going to do num or not? So it's a great question, and the answer also depends for transforaminal on which disc you're operating on. So L5-S1 is the hardest one to get. And L4-5, L3-4, L2-3, those are all pretty easy. Normally easy, when I say, should qualify that, normally easy. Shot? Hold on. Shot? Yeah. So something that a lot of people don't understand is there's 4 zones there's actually 5 zones to the spine where herniations occur that we care about. Central, which is in the middle, paracentral, which is just off to the side, lateral recess, and foraminal. And then extraforaminal, which is outside the foramen. So there's 5 places. 99% of symptomatic disc herniations that cause back pain or leg symptoms, radiculopathy, they happen in the lateral recess or the foramen. And that's the 2 zones where we can get to the best with this surgery. And you cannot get to very well at all with normal laminectomy, microdiscectomy, or other types of surgery, because the nerve root, the ligament, the facet is all in the way for other types of surgery. Whereas for us, it's not. We have direct access to the foramen and the lateral recess herniation. We can even get paracentral, especially paracentral at 4-5, 3-4, 2-3. So this is the best way to fix all disc herniations in the lumbar spine that need to be fixed. Well, I'm glad you asked.
We have another question.
Oh, we can also get extraforaminal with this technique. I just have to turn the scope and look to the laterally, and that's extraforaminal. Yeah, sure.
This next question coming from Dale, once more on Facebook,
Yes, of course.
asking why are other surgeons not using this procedure?
Well, Dale, we get this question about 5 times a week. And the answer is, number one, this is a very advanced surgery. They don't know how to do this surgery. Okay? They don't know how to do it. They've never been taught. It's such a new technology, they don't even know it exists. Second reason is the surgeries they're currently performing, these other surgeons, are much higher paying to the surgeon than this surgery. Surgeons make much less money doing this kind of surgery. And unfortunately, surgeons these days are recommending surgery based on how much money they're getting paid. That's what they're deciding. Rather than what's best for the patient, what's best for the surgeon. You all know what I'm talking about. Some of you don't, and that's okay. You don't know, but you will know someday. Unfortunately, we all wish our surgeons would recommend the best treatment for us, but they're going to recommend the best treatment they know how to do for you, okay? Which may not be the best treatment for you. In the case of back surgery, it almost never is. Most surgeons have no clue how to do this surgery, so they're not going to recommend a treatment for a patient that they don't know how to do, because they're not making any money off of it. You don't get money by referring patients to other doctors. I know with lawyers you can make a referral and you get like 15% referral fee. But with doctors there is no referral fee. It's illegal to get a referral fee. So doctors keep the patients and they just treat them with whatever they have, right? Well, that's not what's best for you. That's why patients travel. They travel to get the best care from the best surgeon, wherever it is. And honestly, if you're going to have a pimple popped on your face, I'd probably go locally and just stay with your dermatologist where you live. Can't be that hard. But when you're having spine surgery, it's a different issue, right? Brain surgery, spine surgery. We're used to people traveling, right? Shriners, you've seen the advertisements on television. Shriners Hospital for Children, or Arnold Palmer Hospital. People travel hours and hours to get to these special hospitals that treat these special types of patients, right? In the case of Arnold Palmer and Shriners, it's just kids. That's, they're special because they're kids. But, adults need special treatment too. And it's not just kids that need special treatment. So why would an adult not travel to the best for themselves and get the best back surgery? They should. I mean, after all, if your surgeon does a bad job with your back, you're going to pay for it the rest of your life. You're not going to be able to do very much. You could lose your job. You could lose your spouse. You could lose your life. That's serious stuff. So, I recommend people go to the best doctor for their problem. Don't go to your local doctor just because they're local. That's a horrible reason to go to a doctor, because they're nearby. Go to a doctor because they do a damn good job of what they do, and they're going to do the best job for you. And unfortunately, if your doctor's not doing this surgery, they are behind the times. Fuck, these pieces of herniation just floating around. Pain in the ass. Great question. I'm glad you asked.
We have another question.
And I'll just say one more thing about why don't other doctors do this. Yes, it's an advanced new technique. Yes, it pays a lot less to the surgeon than fusion does. But there's another reason. There's a few more reasons. One, they're not being taught this surgery by their university where they train. And two, they don't have the equipment to do this surgery. This surgery requires, I mean, I used to say $10 million, but now I know better. It's a lot more than that worth of special equipment. I mean, that's what I paid, was $10 million. I had to borrow the money. And I just know that most doctors aren't going to borrow $10 million, $20 million to take better care of their patient and get paid less. There's not many people that would do that.
We have about 2 questions.
Sure.
This next one coming from Denise once more on Facebook, asking what type of anesthesia is the patient under? General, intubated?
That's a great question. This patient is under twilight anesthesia. They're on propofol, a little Versed, a little fentanyl. I have an anesthesiologist, Dr. Berndes, the best anesthesiologist in the world, right here at Deuk Spine. Can you believe it? And he keeps the patients comfortable under generally propofol sedation with some Versed and fentanyl. Right, Dr. B? Yeah. Sometimes he likes to play with some other stuff, but that's at his discretion. I don't try to do the anesthesia job, and he doesn't try to do my job. So my responsibility as a CEO and founder, find the best anesthesiologist, let them do their job. You know, I don't interfere. So he does what he thinks is best, but we do coordinate with each other. You know, sometimes you'll have a patient who has really bad sleep apnea. They don't respond well to the anesthetic. He tries to give them some anesthesia and they just stop breathing. Well, that patient really needs to be intubated and be under general anesthesia. Secure their airway, prevent them from becoming apneic and having a complication. So we'll put that patient under general endotracheal anesthesia. But rarely do we ever do that. Rare. But the vast majority, like this patient, under propofol sedation. All right, we're done with this disc. We're going to move on to what? The last one? And then we're going to do our DPR. Everyone agree? I just want to get this tiny little bit left right here. I'm pretty happy actually with the overall progress. I was really worried in the beginning when I had trouble getting into 5-1, you know, because of the facets, but it's actually gone better than I expected it to. We've gotten kind of lucky. Any other questions?
Yes, we have another question, another question coming from Mud on YouTube. Mud, asking, what is the percentage of disc clearance in L5-S1 have you had in your experience? My father has a large L5-S1, and the local surgeon said no one can get large discs in male patients in transforaminal. He prescribes interlaminar and has been doing it since 20 years. By the way, thank you for answering my questions.
Oh, you're welcome. Listen, you're a surgeon. That guy's been doing it 20 years. I've been doing it 27 years. So I've got 7 years on them. And here's the thing. All right, I'm going to tell you the straight up honest truth. L5-S1, hardest disc to get to. That surgeon is correct. Transforaminal is really hard. As a matter of fact, I am literally the only surgeon probably in the world that does transforaminal L5-S1. Only one. Because when I got my training, everybody said, oh, it's too hard, it's too hard. You might get it once in a while, but I've been doing it for 18 years now. Okay, I've done literally 1,500. Now, am I going to get 100% of his disc herniation? Absolutely not. I will not get 100% at L5-S1. I don't get 100% of anybody's disc herniation at any level, and L5-S1 is the hardest. But will I get enough of your dad's herniation to get rid of his symptoms and give him the rest of his life in pain-free? Yes, I will. That is, I could probably guarantee it, but I'm not going to sit here and say that. But my surgery has the highest chance of getting your dad pain-free with this surgery. Now, he will still have some herniation there. Up to 50% can still be there, okay? And that's fine, but his symptoms will go away. How do I know? Because I've been doing this for 27 years, and I've done so many of these 5-1 surgeries, and I know I can't get all the herniation, but I get plenty enough to get rid of the patient's symptoms. I've never had a patient where I did the 5-1 and they still had symptoms at 5-1. Never. Not one. So I know the surgery works even though we don't get rid of all the herniation. So the other doctor's correct in that shot. 5-1 is very hard to get all the herniation. He's right. But he's wrong in that it doesn't work. It does work. And you don't have to get all the herniation to have a great result. Okay? He's going to screw your dad's back up. And I'll tell you this. He's going to do that laminectomy, partial fascectomy, remove the ligament, facet joint, drill it away. Your dad's going to be back very quickly for a fusion because that surgeon's going to weaken his spine. He's going to take enough bones and ligament out. Your dad's 5-1 is going to start wobbling around like a, what are those tops, you know, the spin tops? When you're a kid, you pull the string and it just wobbles around everywhere. Huh? Not a weeble, but, you know. Yeah, that little top that spins. All right, here we go. Great question, by the way. I appreciate you asking. Thanks for sharing. Shot? Yes. We know we're in, right, Luis?
Yeah, yeah.
All right, let me just come off because that guide wire is. Where's the guide wire?
Yeah, yeah.
Is it?
Yeah,
You sure?
yeah.
Shot? Jordan, you're playing tricks with that fluoro? Jordan? So what's happening, just so you're all aware, 5-1, left side, and it's not, you know, anything other than the arthritis. Those facet joints are massive, folks, massive. The problem is, what I mean massive, I don't mean, oh yeah, he's got big facets, that's cool. What I mean, pushing my probe away from where it's supposed to go. They're trying to redirect me, and I don't want to be redirected. You know, I can't let them redirect me because they're going to redirect me somewhere I don't want to be. Take this. Let me just see. Yeah, I think we're good. Shot. You understand what I'm saying? So I just got to be really careful here not to be redirected improperly. Whew, that was tough. All right, we're going to get this guy. We'll be done with the disc. 6 discs, 1 surgery. Unbelievable, huh? And then we're going to get his facets because he's got bad facet pain. Shot. I met him on, what, Zoom? Yes. Figured it out on Zoom. Go ahead. Made my recommendation on Zoom, and here he is getting fixed. Great questions, by the way. Any other questions?
Yes, we have another question coming from Tracy once more on Facebook.
Yes,
Ask-
Tracy.
Asking any idea what nerve or nerves might be involved with nerve pain down the front of the thigh. It occurs when I lift my leg or roll over in bed. I believe I have piriformis syndrome. Could it possibly be referred pain from the
Yeah.
piriformis problem? I also have nerve pain all the way down to the top of the foot. Always appreciate your insight. Thank you.
Yeah. So Tracy, first of all, piriformis never causes pain in the front of the leg. Never, never, never. However, the most common cause of pain up there in the front of the leg when you lift your leg up would be your hip joint and arthritis of the hip or a labral tear. Labral tear. We could figure it out at Duke Spine. But it's rarely a pinched nerve. But if it is pain in the front of your thigh from a pinched nerve, the most common pinched nerve is called the lateral femoral cutaneous nerve, aka neuralgia paresthetica. I need a lift on my lead. Jordan, not you. Sorry, Jordan. I won't. I need somebody to lift my skirt, but I prefer it not to be a man. Sorry. Nothing against you, Jordan. I love you. I just can't, I'm sorry. Oh yeah, that's perfect. It was my skirt's falling down. Oh, you know what? Do it one more time. Okay. Then there's a strap on the right. Let's lift it a little bit higher. You see that strap on the right? Yes, pull it so it tightens it so it won't fall down. There we go. All right, thank you. So some of you are wondering why I'm wearing a skirt, but the reason is that it's a lead skirt. And we wear lead skirts, spine surgeons, some of us do, to take some of the weight off of our shoulders, right? Because we have to wear lead, but the question is, do you wear a full gown lead, where all the weight's on your shoulder, or do you wear a half and half, where half the weight's on your shoulder, half the weight's on your hips? I chose the half and half, so I've got a skirt. I've been using it for like 20 years. And yeah, anyway, I've lost some weight, so my skirt is falling off. Anyway, which is good. It's a good thing. Good thing to be losing weight. I was too fat. Now I'm getting healthier. I want to look like Luis. I want to be a ladies' man. Hey, it's all talk, man. It's just words, right? All right, any questions?
No current questions, so we do have a comment coming from Mud once more on YouTube.
Of course.
Following up on what they mentioned with their father on their previous question, they said, pain is not the symptom, but numbness and weakness of leg due to compression, and we are worried. Thank you for providing answers and hope, and he says he does not, he does it under general anesthesia. Thank you so much.
Yeah, oh, sure, I understand. No, you're right. The other surgeon would do his surgery under general. Your dad would be asleep. Is it a bad surgery? No, it's not a bad surgery. What the other one is proposing. Is this better for your dad? Absolutely. It's much better. Why? Because have you shown the microdiscectomy video? Laminectomy
We
video
have
yet?
not. No, not yet.
Yeah, why don't you show him what it looks like?
Copy that.
Yeah. As big of an incision, but it's pretty darn close. All right, welcome back. Sorry for the grotesque, highly grotesque videos, but that's what a laminectomy looks like. And a laminectomy is part of a microdiscectomy, just unilateral laminectomy. So the surgery is quite bloody, but the good news is our new website will show a very nice microdiscectomy, right? Henry has kind of put that video collage together.
Yeah.
You're going to see some steps in the microdiscectomy through a microscope so you can see it nice. We were just talking about my grandmother, and God bless her, she passed away years ago. She's from Egypt, but Armenian, and she left Armenia as a child in 1916 because the Armenians were being slaughtered by the Turks, by the Ottoman Turkish Empire. And she didn't speak any damn English when I grew up. She only knew how to say like two things. Number one, I love you. And number two, thanks God. And so that's all I heard from her. Thanks God and I love you. Thanks God for my grades and my performances. And I love you for just I love you. You know how it is with grandmas, right, Henry?
Oh, of course.
Grandmas.
Oh, my goodness. You love them, though.
Yeah.
You gotta love them.
Yeah. She was a great cook. I mean, she loved cooking. But she didn't speak any English. She just cooked quietly. You know what I'm talking about, right? I'm sure little Jewish grandmothers are the same way.
Yes. I had one grandmother who was just a phenomenal cook, and then one that knew that food existed.
No. Really?
I say that with all the love, though, because like she's just unbelievably sweet and kind and all. But, you know, when it comes to food, you know, it's just what it is.
I don't know if I ever told you, I think I told you guys a story a little bit about my roommate in medical school, Aaron Cohen Gadol. And Aaron and I both, see, when I went to med school at USC in Los Angeles, I had no money. I was dead poor. I had like zero, not a dime to my name. I had to borrow all the money for education, my tuition, $30,000 a year at the time, and what was it, 94? When I started, 94, 30 grand a year at USC, it was a lot. And I had to pay 10,000 a year. I needed 10,000 a year to live, like my dorm plus my food. 10 grand. I lived off 10,000. The 40,000 I had to borrow for med school. Anyway, I came from UC San Diego, and I found out that there was a dorm called the nurses' dorm. And the nurses' dorm at USC County Hospital was literally like a 100-year-old building where the nurses, back in the day, like a long time ago, 100 years earlier, where nursing, like the nurses used to go there and live there. Like they lived on campus, right? And they would take care of patients at the hospital, and they would live, the students would live on the dorm. Like nowadays, nursing school is just kind of like, you go to school or you do it online, but back then it was like a boarding school, you know? So the nurses lived in the nurses' dorms, but long since had that been abandoned, and now the nurses' dorms, which were absolutely tiny rooms, the smallest room you've ever seen in your life. So, but they were cheap. I think I paid $200 a month to live there, right, for med school. Well, Aaron Cohen Gadol, my roommate, was the same way. He's Jewish, right? He looked for the best deal. So we both happened to find the same best deal, right? And they put us together because we were both from UC San Diego. We both graduated UCSD. But Aaron, he didn't have a car. And he had no way to get back to San Diego. But I would go every weekend because my girlfriend was in San Diego, right? So we had a deal going. You're going to love this, Henry. I had no food. I had no money. But I had a car.
Yeah.
Aaron, on the other hand, never ate out a single day of his life. Every meal was his mother's cooking. Every single meal. And his mom would literally prepare a giant a giant cooler of food every week and fill it with like the most delicious Israeli food in the world, like I've ever had. It was so good. It's all kosher, delicious, fresh. So I would take Aaron home every weekend to San Diego, drop him off at his house, pick him up on Sunday as we head back to med school. And in exchange, all my meals were taken care of by him and his mom. Like they literally gave me, she made enough for both of us to eat.
That's amazing.
Oh, dude, it was, for like 2 years, all I ate was Israeli food. Oh, man, that was a lifesaver. You know, it's like the little blessings in life that come along and they just make a huge difference.
Oh, 100%. I'm sure that of itself went so far just
yeah.
in what you needed to do.
And we developed a really good friendship as a result.
Oh, most definitely. Yeah.
And, you know, he's in Iowa now, and he's doing neurosurgery for a big university, doing skull-based brain surgery and tumors, and I'm doing this. But we still maintain a friendship. We see each other. He's got a family now. I got him in the gym the first time in his life. He had never been in a gym before. You know? Never worked out, never went out to dinner. Never went on a date. But I actually got him to start dating, to go to the gym and work out and take care of his body. You know?
That's the best.
Yeah.
That's a good friend right there, you know?
Yeah. Yeah, we helped each other. 8. Thank you. Great job. We're going to get this facet treatment done. It's the right side, and I'm excited for this patient. I think he's going to do really well. I'm a little worried about him because like I said, he's a pro athlete, and he is going to push his back early, and I hope he doesn't go too soon because he needs to give it time to heal. He had a lot of problems here. We've cleaned out 6 discs. That's the most I've ever done at one time, and I made an exception for him to get it done, help him out, and I hope he actually, you know, gives himself some time to heal. All right, let's get this closed here, Luis. For some reason, I need to bring it together. Do you have an Adson? All right, that might work right there. Thank you. Your hands are better than an Adson, Luis. Good. Yeah. So he's got a little tissue trauma. How much fluids is he taking? Couple liters?
No, we're on 1,700.
Yeah, so he's a little bit edematous, a little tough getting his incision closed. Right side?
Yes.
Everyone agree? Okay, we're going to shift straight into our Deuk plasma rhizotomy for the facet joints. Right, 3, 4, 4, 5, 5, 1. We're not going to do a separate broadcast. We're just going to go straight in. 3,
Perfect.
4, 5, S1. There it is. I can see it. And the incision should be exactly right here. Go ahead. Yep. No, a little north. All right, that's fine. Just start there. All right. So I'm heading in. I'm going to go up to number 3 first. Any questions about the surgery so far?
At this moment, no current questions.
Shot? All right, so 3, 4, 5. That's 3 right there. I'm really excited for this patient. I really hope this works. Shot? I think it's going to work well. So it's really, that's called the transverse process. And what's really weird is the transverse process and the facet joints are really far back. But his pedicles, remember his pedicles, they're really short. And his spine is really far forward. So the spine is far forward, but this part of the spine that's in the back is actually pretty far back. So how is that even possible? And there is an explanation. And that is that his vertebral bodies are very long. Shot? All right. So I need to move south. There, let's see. Got to be exactly the right spot. Shot? Yep, that's the perfect spot right there. See where that tip is?
Yes, we do.
I feel like it's being deflected a little bit. Let's just verify position. Shot? It's a little low. I'm not really happy with that. Shot. Right there, shot. All right, so I feel like I'm on the transverse process, which I want to be. I am. I just need to move more medial, which I'm doing right now. Shot. All right, so that's really the perfect spot to deaden the pain nerve here. Now he's going to have some soreness in his back, I have no doubt, because he's got swelling from the procedure. He had 6 discs done, and that's a lot of work to do on one person at one sitting. And typically we break it up, but he wanted to get it all done in one shot. I don't blame him. Get on with life, minimize the downtime. Shot, I'd probably do the same thing. Any questions?
No current questions, but we do have a comment coming from Steven on YouTube. And this is a comment and or seeking advice from Steven at saying, Doc, I recently had an NB bone CT SPECT scan for severe thoracic back pain. The doctor said I have thoracic spondylosis, and the scan marked increase in radiotracer at the opposing end plates at T6, T7. He recommended a fusion. Thank you.
Yeah, you don't need a fusion. We can help you at Deuk Spine and fix the pain without fusion. We treat the same disease, the thoracic disease. We're done, Dr. B. We treat the same thoracic disc problem, pain, with our Deuk laser disc repair. My advice to you is do a free MRI review, mri.deukspine.com. Look us up and do a free MRI review. Thank you, Louise. Thank you, team. And figure out if we can fix it with the laser. But go check out our YouTube channel, go to playlist, go to thoracic Deuk laser disc repair. We've now done 30 patients with thoracic disc pain like you have, 30 in the last 4 years, because there's not a lot of people with thoracic pain. We've done 30, and our pain relief is 99% on average, 99. So if we ask the patients, and that's 1 year after surgery, average 1 year. So if you ask your patients after surgery, how much of your pain did we get rid of? They gave us answers like 95, 100, 100, 100, 95, and the average was 99, and that was 1 year after surgery. So we have the best treatment. It's the least invasive. You don't need fusion. My advice is that's what I would do. Any other questions?
Yes, last but not least, coming from Mud once more on YouTube, asking, so with your procedure, can we expect enough clearance of disc to restore strength in the leg and the sensation?
Yes, you can. With this procedure I just did, all the patients I've ever treated have had their strength come back. Now, when they leave here the next day, about 75% of them, their strength is back to normal compared to, having weakness for a few years from a pinched nerve. And about 50% of them, the numbness is gone. You need me? Oh. So the answer is yes, strength and numbness go away. Strength goes back to normal.
And that is
all
it
right,
for
Henry,
questions.
we got to wrap it up. I got to talk to the anesthesiologist.
Not a problem, of course.